Ready to go.
Hi, welcome everybody to our webinar tonight on vaccines for people living with autoimmune disease. My name is Linda Wilhelm and I'm president of the Canadian Arthritis Patient Alliance. We're really lucky to have Dr. Janet Pope with us, a rheumatologist from London, Ontario, and a professor of medicine in the Division of Rheumatology at the University of Western Ontario, also on CAPA's Medical Advisory Committee, and we're so grateful for her support. We're just going to do a land acknowledgement. I want to acknowledge that we all gather and work on traditional, ancestral, and unceded Indigenous lands, and I'm coming to you from the traditional, ancestral, and unceded territory of the Wabanaki, Mi'kmaqi, the Wolastoqey, and the Wasapikuk, and I live in New Brunswick. So just go through a few slides here, doing an introduction for CAPA and what we do. And so the next slide is we're a virtual, grassroots, patient-driven, independent organization. This year is our 20th anniversary, so we're really excited about that. And we believe that people living with arthritis are experts, and they provide a unique perspective that is often not included. We identify gaps in information, and we reach out to arthritis patients to develop resources for other patients. We help patients and people who support them with understand arthritis and talk to their healthcare providers. We do a lot of collaboration with other patient organizations, representatives from government, researchers, healthcare professionals, industry, other not-for-profit and patient organizations. We communicate news on health policy, research, technology, and emerging issues. And we participate in discussions and activities to communicate the patient perspective on arthritis in our care. We're online. We're very active on, we have our website, www.arthritispatient.ca. We're active on Facebook and Twitter and Instagram and our YouTube channel. This webinar is being recorded so we can put it as a resource for patients who couldn't be with us tonight, so they can come back and look at it and learn about what they need to know about vaccinations. So get involved. You can sign up for our monthly newsletter, and we want to thank GSK for supporting this webinar. I personally have no disclosures. I'm a volunteer for CAPA, and I will let Dr. Pope take over with her slides and stop sharing my screen. So
great. And thank you for those attending. And I think there will be a value add for people to watch it later, some for the first time, and some will want to watch it again, because I'll be covering information, but at a high level. You don't usually want to get too much into the details, I think, unless if there's specific questions. And I'm really talking broadly because vaccinations are quite a broad topic. And we'll also talk about why are we even talking about it? Why is it important for patients? So I kind of named it a little bit sort of funny, more than a jab in the arm. So for people living with rheumatic conditions, there's so many, so I can't always on the general part get into each disease, but give some generalizations and especially use rheumatoid arthritis as an example, but there are many more studied ones. And these are my disclosures. So if you go to the Health Canada website, which I've linked there on the bottom or showing, these are the diseases that we have people vaccinated for. Some already were vaccinated as kids. So there's some that you need boosters for. There's mostly non-live ones, but MMR, measles, mumps, and rubella, and rabies shots are live. Almost all the other vaccines that we get are non-live. And the shingle shot non-live one is actually preferred and better protection. And of course, COVID vaccines are added to that. Well, what we do know is that vaccine rates in people living with immune diseases are going up. So you can see from 2009 here and over to up to 2019, over a 10-year period, 82% were getting their influenza vaccine. This is not from Canada, by the way, it's data from elsewhere. And you can see pneumococcal went up. It's recommended for all immune suppressed people at this point in time. And Hep B also went up, and it's been recommended since around grade 8 in Canada for many years. So that's good. So basically, every 10 years, you should get your tetanus shot, and tetanus is mixed in with its TD, tetanus, diphtheria, but often it's polio might be in there as well. So it's a combination vaccine, different, it might vary, but it's basically every 10 years. And that's supposed to be when you're 15, well, 5 years old, but 15, 25, 35, 45. So if you think of your age, and you can sort of look and think, oh, did I get my tetanus shot the last 5 years? Chances are you haven't, and you should get it. Shingles shot, it is 2 doses. The shingles shot I'll talk about starting at age 50, but it's changed now. The shingles shot, Shingrix, which is the one that's not live and is better, can be given at any adult age to immune compromised people. So you can get your shingles shot really once you got diagnosed, say with rheumatoid arthritis or polymyalgia rheumatica or what have you. Flu shot every year. Pertussis is an adult, 1 dose, and during each pregnancy, interestingly. So that's pertussis. Pneumococcal, 1 dose at age 65 or older, but there's another pneumococcal vaccination for an immune suppressed person once. So that's the Prevnar, and the other pneumococcal is a different one. I'll talk about that. Hep A, maybe. More for travelers. Hep B, all adults are recommended to get it, often starting in the 80s for kids. HPV, all women and men should get it up to a certain age if they haven't already gotten it. So why do we talk about this? So this is RA versus healthy adults. So the RA patients are in blue, and you can see at every age group, 21 to 30, up to and including the over the 71 to 85-year-olds, RA has more shingles than healthy adults. And it's often about 2 or 3 times higher. And so that's why, and this is over 50,000 RA patients. So it's quite a good study, very robust. So that's why we talk about shingles. And then some of our drugs like prednisone, JAK inhibitors will also increase reactivation of shingles. So JAK inhibitors makes your shingles about twice or a bit more than twice as likely as, say, if you were on a drug like adalimumab or etanercept or other drugs that are advanced therapies. So it also increases the risk, and that's well known. So shingles vaccination. So shingles is vaccinating against the varicella zoster. That's the chickenpox vaccination, or chickenpox virus, and we don't want it to wake up. Your chickenpox virus is stored in nerves in your dorsal horn of your spinal cord, and under stress, sometimes under a lot of sun, sometimes with meds, and sometimes who knows why, it can wake up and reactivate. So Zostavax we don't use very much anymore because the Shingrix is better. So anyone 18 years or older who's immune suppressed or immune deficient, and they don't explain that, so really kind of almost anyone on many of our drugs like methotrexate would be eligible. And it's usually given first dose, second dose in 2 to 6 months. But they say if you're immune compromised, you can even get it first dose and 1 to 2 months later, the second dose. So a little bit faster. So that's it. And then probably 5 years after Shingrix, or if you're Zostavax 4 or 5 years later, if you've had Zostavax 4 or 5 years ago, you should probably get Shingrix now. And Shingrix will probably need a booster every 5 years, but we're not sure of that yet. But that's what the data look like. So these are comparing them. But why do we talk about Shingrix, and why has it overtaken our usage? Because it's not live, so you can't get shingles or chickenpox off of it. So you can't reactivate and get chickenpox from it, but it's more effective. So it's far more effective. So safety, it's been looked at on some patients with RA, rheumatoid arthritis, and it was safe, and in general did not flare rheumatoid arthritis in general. There were some side effects, but very mild. Okay, what about if you're 60 or older? So again, flu shot annually at age over 65. There's a quadrivalent flu shot, shingles shot, but you can get the shingles shot now at 18 years old or older if you're immune compromised or on immune suppressive drugs. Pneumococcal vaccination, we'll talk about that. And then at the age mid-decade of age 65, 75, et cetera, you're to get your diphtheria, tetanus, and a pertussis, and the pneumococcal other second vaccine when you're 65 or older. So Prevnar at any age as an adult who's immune compromised, and the other one, Pneumovax, when you're 65. And that's all you need then for that to prevent pneumococcal pneumonia. So again, if you're healthy, these are the recommended ones. And you can see Hep A, if you're traveling, maybe. Hep A isn't all that effective for a vaccine, but for some diarrhea, if you're going to a resort somewhere, it could be from hepatitis A. HPV, I talked about. MMR, if someone's pregnant, because it can affect the baby, rubella. If they're not immune, then after they're pregnant, they'll be vaccinated, so revaccinated. Meningococcal is only with outbreaks. The chickenpox is usually kids, they get the varicella, but a rare adult was never exposed to chickenpox, and instead of getting the shingles shot, they get the varicella shot if there's no known history of chickenpox, because it's a stronger vaccine, and then travel vaccines sometimes. So pneumococcal, it's a bit confusing, but it's to treat against one of our most common pneumonias, most common bacterial pneumonia, strep pneumonia. You've probably heard of streptococcus or strep pneumonia. And it can also prevent against invasive pneumonia, which is pretty bad, invasive disease. And so, as I said, if you're under 65 and immune compromised or immune suppressed, Prevnar once. At age 65, you add Pneumovax and you're done. They're changing some of the, not the recommendations, but some of the actual vaccines might change. So there's Pneumovax 30. I don't know much about it because not out yet here. And Prevnar will still stay as Prevnar 13. But if you got Pneumovax and didn't get Prevnar, then you wait a long time to get Prevnar. If you got Prevnar, you can get Pneumovax within only a few weeks. So there's a weird order effect thing about it. But mostly under 65, you should have had Prevnar if you're on methotrexate, drugs like that. And at 65, we're all supposed to get Pneumovax. So we do get okay responses. This is RA patients on a biological TNF inhibitor, adalimumab, looking at influenza and pneumococcal vaccination positive rates. And you can see here, they're looking at the amount you get to the antigens, and they're looking at if you were on a placebo adalimumab or the real, which is gray. And you can see the responses are about the same. So we're not dampening the responses on the TNF inhibitors, we think. And that's probably also mostly true for COVID as well. TNF inhibitors probably don't dampen COVID response. There's another study looking with a JAK kinase inhibitor. And again, satisfactory response if you hold methotrexate for 2 weeks or if you don't hold. So not holding, if you have it at baseline, that's the middle of the first table here, 65% response. Whereas if you have no methotrexate for when you get your shot and you hold it for 2 weeks, you get a response more like 90%. That's for pneumococcal. And for influenza, not so much different. That's not always shown, but it's shown with methotrexate. We should hold methotrexate usually for influenza for 2 weeks. Recent data, hot off the press, not sort of in publication, holding methotrexate 2 weeks after each COVID shot, if you're not flaring, will give the best immune response. So basically, immune compromised patients should have annual flu shot. And if you're over 65, the quadrivalent should have the Prevnar, and at age 65 should have Pneumovax, that's for the pneumococcal, should have more COVID vaccines. So 3 as opposed to a series of 2 because of being immune compromised. And then all the other shots were to get. So some few differences. Okay. Why, again, are we talking about all these agents to vaccinate against? Because infections are higher in rheumatoid arthritis than the age and gender match population. And pneumonia, you can see it's almost twice as high. Skin and soft tissue infections, cellulitis, boils, things like that, 2.5 times more than that higher. Bacterial infections and sepsis, so bacteria in your bloodstream, 1.5 times higher. Low rates, but 1.5 times higher in RA. Infection in the joints, septic arthritis, 21 times higher in RA, and osteomyelitis, infection in the bone, 10 times higher, more than 10 times higher in RA. That's why it's kind of important. Okay, this is showing that even low doses of prednisone have an increased risk of infection. So this is saying severe infections in early rheumatoid arthritis patients followed for 10 years, if they're on 10 milligrams or less, even less of prednisone, 5 milligrams even, they have more severe infections with prednisone glucocorticoids 7.6% versus without glucocorticoids 2.4%. So there's higher risk of infection. So that's why we talk about it as well. Influenza and rheumatoid arthritis is a little bit higher, or particularly in the young age groups, because we think of influenza doing worse for people who are older, which is still in general true. Sometimes pregnant women and sometimes kids have higher bad outcomes than, say, a medium age for a middle-aged person in some strains, but in general, older will do worse. And you can see in the younger age group, rheumatoid arthritis is having more influenza, not always worse influenza, but more often getting it. So that's why we talk about flu shot. So in our early arthritis Canadian cohort, the CATCH cohort, 1 in 3 patients prior to rheumatoid arthritis got their flu shot, but after they got rheumatoid, so we hope us or the nurses, someone was doing a good job talking about it, half of them were getting vaccinated. And before you got rheumatoid arthritis, it was a bit older age older than 55, non-smoker and more comorbidities. But afterwards, it was still non-smokers. The smokers should also be vaccinated, by the way. But the biggest chance of getting a flu shot after you got rheumatoid arthritis was getting a flu shot ever before your rheumatoid arthritis. Okay, so this says here a nice little study that says if you stop methotrexate, you get your flu shot and you hold methotrexate for 2 doses, 2 weeks, then you restart because we don't want people flaring, you mount a better response. Now the blue is the blue is continuing methotrexate so they don't mount as high a peak on those responses on the graph. But you could be smart and say, well, does it make a difference on getting influenza infection or getting severe infection? And the answer is, I don't know. And I don't know it about the other shots as well. We also don't know it about COVID. We know you can mount a better response holding for 2 weeks, but we don't know, is that more protective or less apt to give severe COVID? I don't know, but we want your shots to work. So we want the best response possible, probably, provided you're not flaring. I don't tell people to hold their methotrexate if they start flaring or already flaring when they get their COVID shot. So timing of vaccination is best before you start your immune suppressants, but we can vaccinate you anywhere along your arthritis or your immune journey. It can be done safely. You can hold for live vaccines, but only MMR or rabies would be the live ones you'd be thinking about, so don't worry about it. And sometimes we'll discontinue or hold your therapy transiently, but not necessarily, because we want you to mount a good response. What about in Canada? So newly diagnosed patients with our diseases that are immune suppressing or where we're going to use immune suppressants, we should do a vaccine history and get on with treating people. You can hold the treatment, but usually if you're diagnosed, we want to get on with drugs like methotrexate right away. So I might not vaccinate you till a month or 2 after feeling better, and then I can hold the drug. Rituximab is a special one where it really does deplete your immune globulins that make a response to your vaccine. So we would like to ideally vaccinate 4 weeks or more before you get rituximab, or 4 weeks or more before you get your next dose. So many, like 2, 3, 4 months after rituximab. We have to also know that our patients are at higher risk of infection and that we can help them with treating them. We also know with COVID is they can prolong the carrier time of the virus longer. Okay, so when we stop, the recommendations from Canada, Health Canada, when we stop high-dose prednisone, or if you're receiving rituximab, you can immunize 4 weeks after stopping high-dose prednisone. I'll probably immunize you if I can't stop it anyway, and 6 or 12 months after stopping rituximab or before your next dose, or just immunize anyway, saying some immunization is better than none, even if your response might be blunted. So Hep B, HPV, cancers are increasing and we can vaccinate against it. And the age of which you can get vaccinated for HPV varies on what you read, from 25 to 45, because there are some strains that even if someone's sexually active, you might not have been exposed to all HPV strains, so we can still prevent cancers of certain strains. Influenza, pneumococcal herpes zoster. So what about traveling? Maybe hepatitis A, get hepatitis B up to date. Right now, you have to get a COVID test in some countries before you travel, not so many anymore, but you might need some other ones, yellow fever, typhoid shot. That's traveling to places in Africa, very special places where you'll have to. The cholera shot is better than it used to be. When I trained, it was only about 1/3 effective. Now it's about 2/3 effective. The new cholera, it's not that new, but the newer cholera. So you can go to a travel clinic or you can ask your family doc if you're traveling somewhere unusual or where it's not like a high class resort with really good clean water at it. If you're traveling, like say, to do humanitarian things, you might need some shots, but not all people will need to be vaccinated going to even uncommon countries. What about monkeypox? So there's already, as of June 8th, 920 cases in the world reported beyond Africa, where it came from. And by the way, monkeypox, there's probably double that now, and it's spreading without people going in traveling. It's in 24 countries. So what is it? It's the monkeypox virus, and it's a member of the smallpox family, but less severe. The new name might take the monkey out of it and be HMPXV, but that's not agreed upon yet. And infections are usually mild, and the risk to the general population is low. But on some websites, such as in the UK, for some reason, homosexual men are at higher risk. I don't really know why. I don't think it's a sexually transmitted. I think it's some airborne virus, but they might start giving smallpox vaccinations to some very select immune suppressive or high risk population. Should we worry about it? I don't know. I mean, I think we have more things to worry about than the monkeypox, and people my age got smallpox vaccine, so we're probably immune, but chickenpox might react a bit. And we've all in Canada, every adult over the age of 40 has had chickenpox, virtually, if you were born in Canada, and the younger people were getting vaccinated against chickenpox. So I don't think it's going to be a severe thing, even if it spreads. But right now, it's not spreading like wildfire. It's just spread a bit. But you can see a lot of countries have it, and we don't really know why it's spreading around or how, but it is. So it's not common. There in West Africa and Central Africa is where it usually hangs out, and it's in wet areas, rainforest areas. But the unusually high numbers is very strange. So we don't exactly know how it's spreading, and it was spreading before travel became like quite a lot. Now there's a lot of people traveling, but anyway, I think it's not a worry, but just keep your eye out on news stories, but I wouldn't lose sleep. Okay, COVID vaccines, I want to talk about that, and then we'll get into the questions. So believe it or not, all these have been approved in Canada, not all of them released, but I was a little bit surprised. I had to check the website I was on. AstraZeneca, no one's getting that too much anymore. Janssen, hardly anyone ever got it because there was a problem in the making of it when Canada bought a big supply, and then I think it expired, sadly. And they wondered about a contaminant when they made it. It was like a weird batch thing. There's no problem making it now, but we don't seem to get it. Never heard of the next one. The Moderna one you've heard of. The Novavax has been approved but isn't available yet, and that's kind of interesting. I'll talk a bit about it. The Pfizer one you've heard of. So they're all approved in by Health Canada by emergency release usually. The Pfizer one, it was 2 doses, 3 if you were immune suppressed, and then a 4th along the way. Why? Because the response is pretty good. All the ones I'm talking about will decrease the chance of hospitalization or severe outcomes, but none of them make you have zero chance of COVID, none of them. So they decrease the severe COVID because your viral carrier is less and you have some degree of immunity. But Pfizer's not as good as Moderna against the Omicron strains right now. They were equal against probably against Delta or almost equal. And the problem with Omicron is that you're not making good immunity. So some people already have had Omicron 2 or 3 times, and that's unfortunate for sure. So 95% effective in adults, less so now on the Omicron strain, 100% effective for kids. Kids under 5 to 11, maybe 91% effective. So 2 dose for immune suppressed, a 3rd dose at full dose, and now a 4th dose. And you can mix and match Pfizer and Moderna. Moderna is more effective, I'll say it again, against Omicron, but Moderna has more side effects, absolutely. Achier, sore arm, being out of commission for a couple days, more so with Moderna than Pfizer. So Moderna, these are all both RNA viruses against the spike. The spike is your crown, your corona crown virus. So again, fairly effective and a bit more effective against Omicron, maybe was more effective against Delta, but Delta's not around anymore anyway. 2 doses, but if you're immune compromised, 3 doses. And the boosters for other people are, I think, half dose, whereas if you're immune compromised, it's full dose. So you keep getting full dose. And again, Health Canada, well, it depends on the province. When I say Health Canada, that's not true. Provincial guidelines are telling you what you can do in your province, but basically in Ontario, 84 days after the 3rd dose, you could get your 4th if you were on methotrexate and a bunch of other or a bunch of other drugs. So our patients were allowed many of the drugs that I prescribed for people, they were allowed to get their 4th. Then this one, people have been interested in this Novavax, I should say. So it's not against the RNA, it's protein based. It's 2 doses, it's approved for adults. And I don't know when it's coming, but some people theoretically say, this is theoretical, I don't know, saying getting Novavax as your next one as a booster, maybe will give you more immunity. But I say maybe because this is speculation and they haven't done the studies. But certainly you can interchange Pfizer for Moderna and back and forth, and there's an advantage to mixing them up for those. Janssen or Johnson and Johnson, it's viral vector based. It there's nothing wrong with it. It was less effective though than Pfizer and then Moderna at the beginning of the COVID, and therefore it didn't get a lot of traction. And AstraZeneca was a bit less effective as well. However, I say that they all did decrease serious or severe or hospitalized conditions of COVID. So they all did do that fairly equally, but some of their benefit for milder cases wasn't as good. So this is one of 2 studies recently presented at our European Congress, holding methotrexate for 2 weeks after your 1st dose or your 2nd or both doses would give better protection, but we don't know if that translates to less severe COVID. We just don't know, but you mounted a better response. But the vaccine they were given for COVID, and this is from India, is one we don't have, this one called CHAdOX1, but it's kind of like a vector like the way we have Moderna and Pfizer, so you could probably generalize to that. But it was given, and 1 week later, the 2nd dose of the vaccine. So if you got your vaccine, you're off, say your methotrexate 2 weeks, you're back on it 2 weeks, you get the 2nd vaccine, you're off at 2 weeks. The 2nd vaccine had more flares because you were off the drug 4 weeks out of 6 weeks. We never got our doses that close together at the beginning because Canada wanted to give everyone a chance of some vaccine before, except for the high risk elderly, nursing home, Native Canadians. Everybody else was to get a larger interval. And by the way, the larger interval, someone guessed right. It was actually more effective. We had better responses of COVID getting a larger interval between your Moderna first or your Pfizer first and your 2nd, waiting 3 months instead of 3 or 4 weeks. And we did better than the US, who did it on schedule. Well, we did better because we had more people vaccinated, but of those vaccinated, we had less breakthrough infections at the, when I say beginning of COVID, by mid 2020 to late 2020. That's a long time ago now, of course. Yeah, so, and into 2021 early, and different strains then too. Now, this says that if you're on a drug like rituximab, even if you don't make antibodies, because some rituximab patients don't make any antibodies till their third dose of getting their COVID vaccine, but basically you can get a cellular response, which we can't measure, but like we don't routinely measure it, but you can get it. So if you had no antibodies, which you're not recommended to get your antibody titer because it's not standardized, but even if you have no antibodies, we all probably, except for severe chemo or CAR T therapy, will mount a T cell response. So B cells, antibody, T cell response, other ways of the white cells coming in, like recruits and fighting the infection. So that's some hope for our patients for sure. Okay, what about outcomes? So basically, Sasha Bernansky had a nice study that was Canadian data showing that our Canadians who are vaccinated ×3 with immune suppressed rheumatic conditions did virtually as well as the general population. Not as well if you weren't vaccinated, and not as well if you only got one vaccine and they don't have as much data on 2 vaccines, but 3 vaccines you did about equally well. I believe you'll be offered a 5th, and if you've only had 2 or 3, a 4th shot of against COVID in the fall, and that's probably when you'll be offered your flu shot. Why? The numbers tend to go up in the fall, and we probably can guess they will. And we're always like, we can guess what happens in Australia because they're fall is our spring, so we can guess what's happening. The other strange thing is influenza is hanging around a lot longer this year. So if you haven't gotten a flu shot and you're listening to this talk and you want to, we still have some around. So a lot of provinces still have some around. You can get it because they're getting funny timing. They're not funny cases, they're normal flu cases, but they're getting funny timing. And we know the first year of COVID, there was almost no influenza in Canada. So masks worked, even though lots of COVID was spreading, masks were helping us on influenza, interestingly. But influenza went up as, no surprise, as masking went down, no surprise. And as people were traveling. So this is looking at COVID infections of rheumatoid arthritis patients in Denmark. So it's all the RA patients, so many, many thousands, compared to age and sex match control. So 28,000 people with RA. So if you were unlucky enough to be unvaccinated, pink is RA, gray is the general population, age and sex matched. You can see a lot more infections. Partially vaccinated was the time frame between your first and second one, little bit higher on RA patients than the general population. But look at table C of the graph C, I mean. Fully vaccinated, your vaccination rate's the very same. Your COVID illness rate is the very same. And we're kind of like that in Canada. They're not as good as that in the US, by the way, but for some reason we are. But who is getting worse COVID? Rituximab, high dose prednisone. And if you're unvaccinated, you get about almost 4.5 times more COVID if you're on rituximab than age and sex match general population. But if you're vaccinated, you get less COVID, but it's 12 times higher if you're on rituximab than if you're looking at the other patients now vaccinated because they don't mount as good a response. So reassuring data. So that just tells you a little bit about it. I just kind of summarize it there. So what about outcomes? So the biggest risks of doing poorly with COVID are age. Age is a big risk factor. It's our strongest risk. Then heart disease, lung disease, so obstructive lung disease, bad angina, because if you're low on oxygen, you can have a heart attack or your lungs don't work and you get COVID pneumonia, that's why. Then some comorbidities. And in our group, the drugs, the diseases and the drugs that are immune suppressing drugs or autoimmune diseases are a risk factor, but they're a minor risk factor. And some of the outcomes of SARS where we drove people to being almost paranoid. So cocooning's good, but overdoing it, then people were missing their families. Mental health, absolutely. And now fear of how do you start back? Like when do you not mask again or just mask for years? It's going to be very individual. I'm still masking because, well, I have to at work anyway, but I'm still masking when I go out and about because I don't want to make my patients sick. I see immune suppressed people. So I think it's only right and good process for me to mask. And I get my groceries still usually not in the middle of a Saturday because I don't want to wait in line, but I don't want to be exposed to people who aren't masked and are coughing and stuff. So most of our people living with rheumatic conditions, their outcomes of COVID in Canada were the same as age and sex matched other people. There's always a horror story of someone young getting bad COVID or someone old not getting bad COVID at all, which isn't a horror story, that's a celebration. But there's always exceptions to what I'm telling you, but I'm trying to tell you on average. Okay, should you get antivirals or antibody treatment if you get COVID infection? If you're on methotrexate, biologicals, JAK kinase inhibitors, other immune suppressive drugs, or prednisone more than 20 milligrams, yes, yes, yes. So in Ontario, you have to prove an OHIP covered positive test. So you do your kit at home, then you go, unfortunately, to the emergency room or to one of the test centers. They prove that your COVID's positive, and then they'll offer you Paxlovid, which is 2 antivirals, and it's a 6-day course or a 7-day course, and it can decrease severe outcomes of COVID. Rarely, if you can't tolerate it or if you're quite immune compromised, they might give the antibody treatment, which is remdesivir, to try to prevent you getting severe COVID. And it's underused, and some people in the emergency room will talk you out of it. But if you qualify, I tell you, go. Why not? Why wouldn't you want to have less severe COVID? So, and Canada has tons of Paxlovid because it's being, first of all, patients aren't aware because we haven't communicated well. But secondly, when they go to Emerge, I've had, like, when Paxlovid first came out, of the first 5 patients I sent to Emerge, 3 of them were talked out of it, not because they wanted to be talked out of it. They were talked out by the healthcare staff. Oh, it can change your smell. It can change your taste. And that's what COVID can do. So you know which it is. There's drug interactions. You might feel unwell on it. Well, if you're in the ICU with COVID, you don't feel well. So we'd rather you do it. Then there's the Evusheld and other antibodies to, now we're not talking treating mild COVID to prevent severe, we're talking prevention of COVID. So right now, unfortunately, well, fortunately, there's all these monoclonal antibodies, but unfortunately, there's huge drug resistance right now. So the BA1 and 2, that's Omicron variants, and there's a lot of other Omicron variants. So the Omicron variants, there's a lot of drug resistance. So we do have Evusheld, which is one of these monoclonal antibodies. I honestly can't remember which, but we have it in Canada. Health Canada has approved it, and then the provinces decide what they're going to do. So currently in Ontario, if you're on chemotherapy or CAR T, or you've had a stem cell transplant, so very, very immune suppressed people, they'll get it. If you have lymphoma and you're on rituximab, you'll get it. And we're negotiating, because they do have enough supply in Ontario, we're negotiating that people on rituximab should be considered to get it for their rheumatology conditions, vasculitis or rheumatoid arthritis, etc., because they do the worst of all our patients from the point of view of getting into hospital and stuff. They have a higher chance, not of getting COVID, but of getting sick with COVID than the rest. So we don't think every person on like etanercept or adalimumab or methotrexate or leflunomide or a JAK kinase inhibitor, we don't think they'll need it, because we got things to do if they get COVID, but we think rituximab should be included, and we're negotiating to try to get that. So the Ontario Rheumatology Association is meeting regularly with the Ministry of Health right now in Ontario. So one province might have a different criteria than our province. That's the problem when all these COVID shots of when you get the next one, it's based on provincial recommendations, but it's also based on how common and what strains out there. So in Newfoundland, it wasn't very, the first strain wave was very, very uncommon to involve people. But in Newfoundland, I think we're at about the 5th wave, by the way, but at around the 3rd wave, they were certainly catching up and getting more cases. So it depends on where you live. then what's important is there are neat little tools to help healthcare providers. So this is out of Dr. Chris Penny. So he's a rheumatologist in Western Canada. And his group had this vaccination passport to have people kind of carry it, their patients, just like your kids, if they're going to school, they need to have their vaccination little booklet to prove they were vaccinated to get in for kindergarten or whatever they're starting their schooling, whatever age group and grade group. So this is a way of saying this is helping patients know when they need their next stop. And you know who knows it best? Public health nurses and family doctors. They know the rules best. And I had to actually look up the pneumococcal rules because they change all the time. And Center for Disease Control in the US is not totally identical with Health Canada. Similar, not identical. So that's why I looked up the Canadian ones. What about if you're immune suppression, you're having a baby? The baby should be vaccinated, and a live vaccine you might want to do with caution. So the first live vaccine is rotavirus vaccine, but if you don't give it to the kid, they'll 100% be getting it. Doesn't mean they'll be sick with it. It's a diarrhea causing virus. But if they don't get vaccinated early, then they won't get any protection, and it can protect against severe diarrhea. So we think that that's safe for the kids to get, but you would ask if you are on, say, infliximab, that's Remicade or Inflectra, other names of it as well, and you're breastfeeding a baby, you just have to ask your pediatrician or your family doctor. But then the next thing isn't till a year where kids get live MMR, measles, mumps, and rubella. So we don't think any vaccine should be withheld on these kids. Most aren't live, just get the kids vaccinated. So I've talked a lot about the flu shot annually, about the pneumonia shot against pneumococcal, one now if you haven't had it, and one at 65 or older. They're two different ones. I've talked about COVID. I've talked a little bit about HPV, a little bit only about Hep A and Hep B, and that you need your tetanus, which just throws in other things like TD, sometimes it's TPD. They throw in pertussis or polio, depending on what's around, and that's at age 25, 35, 45, the middle of every decade, but you can get caught up if you haven't gotten it. And by the way, the school kids, because they missed about 2 years of in-person school, there's a bunch of school kids, 5-year-olds need it to get into school, but the 15-year-olds have missed their tetanus vaccine. So one of my kids who's graduating from grade 12 missed it in grade 10, totally forgot. And we got this letter saying the kid won't graduate till he gets his shot. Well, of course, I'm pro-vaccines. I'm giving a talk on vaccination, but I got to get my kid vaccinated. We forgot because he wasn't at school where we would have gotten the reminder, and we weren't going out that much to think about, oh yeah, you need your next vaccine. Of course, he got all his COVID shots. So in Ontario, he was allowed to get a third COVID shot as he's now 17, and the 18 plus can get their third shot as well in Ontario. So there you go. So we have some things coming in. So there are some questions, and then some questions will also get read to me because thank you for those who submitted in advance. So this is a question. Someone got a cortisone shot. Is that high dose prednisone, and how long will it make you immune suppressed? Excellent question. So someone got, I think, a shot in their muscle and maybe 2 joints. So that's a high dose of prednisone, but it's mostly locally. For the joint ones is mostly local. So it's not considered severe immune suppression, as opposed to, say, if you were on 20 milligrams of prednisone a day for a month, that's far, far more prednisone than 80 milligrams intramuscular plus 40 milligrams into each joint. It's far more immune suppressed to be on daily prednisone, 20 milligrams a day. So it's pretty safe and not too immune suppressed. So it's a great question. Okay, when it comes to special travel vaccines like yellow fever, and yellow fever might be live too, by the way. It's a bad one. People react to typhoid and yellow fever, sometimes a big swollen arm in some people, but it might not be live. I actually can't remember yellow fever if it's live or not. But when it comes to these special things, how long do you hold your meds? Well, first of all, you're probably going to have to go to a travel clinic to get it. I would say holding your meds, if you're in good shape, your methotrexate 2 weeks after each shot. Problem is typhoid is 2 and yellow fever is 2, I think. So if you're getting them too close together, Kenya, as a for instance, you have to have yellow fever to get in if you're going to small places. Otherwise, I don't think you have to anymore. So it'd be more if you're going to go like live in a village, do humanitarian or visit like the outside of the cities. But I think you can still go on safari without it, by the way. So I would hold 2 weeks of methotrexate after each vaccine if you can. If you can't, don't worry about it. The other drugs like TNF inhibitors, your Enbrel, Humira, and the biosimilar names of those drugs, or infliximab, you probably don't, and golimumab and sertolizumab pegol, you probably don't have to hold. Okay, and then intramuscular shot, you're not too immune suppressed with cortisone shot. Okay, can we open it up because there were some questions in advance?
Yeah, I have just a couple here that were sent in. And one of the things was early on when vaccinations for COVID first came out, there was a lot of conflicting information and confusion.
Oh, it was terrible PR. Yes.
Yeah, we were watching the UK and different things and wondering what, the National Advisory Committee on Immunization wasn't recommending us to get vaccinated. And then because we were not included in the clinical trials, can you give us some insight on why we're not included in clinical trials?
Right. So first of all, it would be great to include all sorts of general population, but I think they wanted to they were worried that if the COVID vaccine turned out to have weird safety issues, they didn't want to make people that are already on a bunch of meds sicker. I think that's the reason. I don't know otherwise. And they probably thought, oh, they might not mount as good a response. And we want to know maybe the optimal response of these things. But the NACI or whatever, it was the worst communication in Canada at that time. It was the Canadian Rheumatology Association had to write a strong letter saying we do not endorse this, that our patients are at actually equal or if not higher risk of getting of outcomes of bad like COVID infection. So they should actually be preferentially vaccinated, and we fully disagree with you. So it was a bad time for PR. Now, it's easier to look back and say, oh yeah, because we were scrambling and didn't know things, but that was one of the most harmful COVID public health announcements, saying that our patients with rheumatic diseases can't get it because they weren't studied. It's like, well, nor were pregnant women studied, and they were to get vaccinated. The Society of OB-Gynecology in Canada made it on same day we made our statement. That same week, they made their statement saying all pregnant women, because there were already known some pregnant women, not in Canada at the time, but elsewhere, had bad outcomes with COVID. So they were recommending from March of 2020 onward that pregnant women should be vaccinated. And at the same time, we were recommending all our patients should be vaccinated and not excluded. And that there's lots of people not studied in this group, and every Canadian should be vaccinated, because at that point in time, naively, we thought we could get herd immunity. And herd immunity is we won't get infected anymore because we have a shield around the most vulnerable because everybody around them is vaccinated. The problem with herd immunity makes good sense. It's true for measles, mumps, rubella. It's true for influenza a little bit. It's not so true for COVID because we don't have a sustained immune response. So we mount usually a good immune response, but it's not sustained.
Yeah. And then the other question I had as well is we get the flu shot and we're probably going to have to get a booster shot. Is there should we space them apart? Can we get them at the same time?
Right. So you can get them at the same time now. So at the beginning, you couldn't get any shot. I had people trying to get their shingles shot and they couldn't have any shot around their COVID shot 1 month before, 1 month after, which was kind of crazy. But I'll put it this way. It was in the context of we wanted people to mount a good response. And we wanted to know the side effect profile. Is it safe in the general population? What are the side effects? So they didn't want to mix it with other stuff because they wouldn't know, will you mount a good response, or do 2 shots dampen your immune response? They don't dampen it. That's why we have, DPT. There's one of our shots that little kids get 4 different things in them. So they don't, giving 2 shots at once doesn't weirdly, in a good way, dampen your response to either one. But it was mostly looking at side effects. So now with the 3rd vaccine in Health Canada said, and Center for Disease Control said, and that's quite a while ago, the 3rd one that was offered to people You can get other vaccines at the same time, no problem, or the same week, no problem, but even the same day. So I gave someone here, a couple people, flu shot, where later that day they were getting their COVID vaccine, because we're not a COVID vaccination site and they have to be in the Canada register. So they already had their appointments booked, but they couldn't get their flu shot at the COVID center that they were going to. So I said, well, I can give you your flu shot and you can get it tonight, no problem, your COVID shot. So we did that because the rules had changed. Great question.
And then the other question I had as well is, you talked a bit about the two different types of flu vaccinations. So there's a higher dose for people 65 and older.
Yeah.
People who are immunocompromised, I've heard, should get the higher dose, but you say that that's not necessary?
We don't know so much as necessary. So there's tetravalent and quadrivalent. So it sounds like quad sounds like stronger or something, but I think tetra is a 4 and quad is a 4, by the way, but they're a little bit different. So in Ontario, the high dose was recommended for over 65, period. They didn't say, oh, if you're immune compromised at 60 or at 50, but I think it's because of how much supply they had, and also because most of our patients, especially if we do hold methotrexate, which I don't always, I'll admit, but if we hold methotrexate for 2 weeks after the flu shot, most of our patients get a very satisfactory response. And flu shot is not 100%. COVID is quite strong on protecting against severe COVID, but we know lots of people get COVID. Some of the flu shots, about, if we're lucky, a good one, like, because they're guessing what will be mutated in Canada when the influenza usually starts in Asia, goes over to Australia, goes to Europe, comes to us in Europe, not quite at the same time, but close. So we guess the mutations, we, not me, the people designing the vaccines. So the flu shot at best is probably only about 2/3 to 3/4 protective. But by the way, the flu shot also protects, surprisingly, against bacterial pneumonia, even though it's a viral thing. And for little kids, less ear infection, which is bacterial, otitis media. So the flu shot has a few other weirdo things to help. And they think it's actually giving an on-target immune response and an off-target immune response, helping you, oh, let's wake up and be vigilant against other infections that might hit us. So they think it's because of the way the flu shot acts. And so kind of interesting. So you wonder if when we're getting our COVID boosters, number 5 to 25, or whatever number we'll keep getting, if we're actually boosting our immune system in other good ways, not boosting to make an autoimmune disease, but boosting to maybe say, oh, it's helping strengthen my shingles immunity. I don't know though if it is. I don't have a clue. I just know the flu shot, they've had many studies showing what I just said in the flu shot.
So if anybody has any more questions, you can type them in the chat, or Lori, if you have some, you can jump in.
Yeah, I think the only other question that I had, since no one else is asking, is yeah, I just wondered if you had any recommendations for families or family members, right? Because you talk about how like we're at risk, right? So because I know I try to get like my kids vaccinated just because they're at school and just like so many germs, right? And just wondered if you had any recommendations or if there are any recommendations sort of for extended family.
Right. So I think first of all, many of us want to get vaccinated for our own health. But also to shield vulnerable people, right? So the vulnerable people might be in your family, like the little kids that can't get vaccinated yet. The Pfizer thing's been approved from babies upward in the US, but we're under 5-year-old, not approved yet in Canada. So eventually the little kids, but the little kids can fight it off okay, probably, if they get COVID. They're not at a high risk of severe COVID, but they can feel pretty sick, and you don't want your kid like dehydrated, and we're all worried about that. The hepatitis thing that's occurring that might be part of COVID, where some kids are getting like liver failure, very uncommon, but very, very scary. And we don't know what's driving. We don't understand that. I don't understand that at all. And I don't think anyone really does. So then also you're trying to shield maybe a parent or an older sib or something, or your uncle who's still around or something. So we're often trying to get families vaccinated to shield the immune compromised person, but also shielding elderly, because elderly is one of the biggest risks. So that's how I would talk about it. And unfortunately, I think you're all aware of some families where COVID strongly, yes, gets vaccinated. Other people in the family strongly, no way, it's my right to not bear my arm out and get jabbed. And that breaks apart families. And you know, weddings are, you know, finally they're allowed to get their wedding going because it was canceled so often. And then all of a sudden they say, well, your mother-in-law can't, like my mother-in-law can't come because she's not vaccinated. It's, I think, please have respect for other viewpoints. Like I don't agree with people not getting vaccinated, because I think, why wouldn't you? But I'm generalizing, but I don't judge. I'm not in someone's shoes and there's mistrust, or people say, you know, I got my flu shot and I got RA, or I had my pneumonia shot and I never felt right since, which they probably felt right. But, you know, you just don't know what they're blaming on what. But on the other hand, people have their reasons. And I don't think judging, obviously, I think that's a bad thing to judge. But I still will say to people, you know, as a physician, I'm not talking to someone on the street saying this, but I say, okay, I see you haven't gotten your COVID vaccines and that you don't want to talk about it. That's fine. But if ever you want to know more, myself or our pharmacist or my nurse, you can call and we set up a little mini appointment to hear more if ever you want to know more, or if you're more on the fence at some point. And they go, okay, thanks, I'll probably not call. And I go, that's okay. I just left the door open instead of slamming it shut. I think that's the best I can do now, because if the people who have had 0 vaccinations are probably not going to change their mind anytime soon. The people that have had 1 and weren't sure might get a second, especially, you know, if case numbers go up. The people that have had 2 and don't want more, sometimes they're open to hearing about it. Or I have people say, I'm going to get the flu shot, but I don't know about my next COVID shot. I had a sore arm and I think it flared my RA. One thing I can tell you is that rheumatoid arthritis, lupus, psoriatic arthritis, ankylosing spondylitis, and other connective tissue disease, the flare rate a month before COVID shot is the same as a month after. Doesn't mean you're not achy 2 days after, but it doesn't look like we're getting sustained flares on average after. But some people do flare their disease, very uncommon. I would say a handful in 100 of lupus and RA patients will flare after the COVID vaccine. Most of them by days 2 to 5, most of whom are just there by the time they phone me and I call in, say, a short course of prednisone, they're all better. But a month before and a month after, the flare rates are the same. And that's very helpful data. Yeah.
I was wondering if I could ask a question.
Yeah, I was going to get to you, Delia. Just 1 sec. This is
I was
coming down. This will be coming down to the end. But Delia, the last question.
I was curious about the Pfizer COVID shots and vaccinations. Like the first 2 had to be frozen, and I don't think they've been freezing the ones subsequently.
Correct. So
that
yeah,
they have included a lot of chemicals that.
No. What the problem was initially was because they raced to get it out so quickly. They didn't know the stability. So they said we tested it in these like deep freezers, and same with Moderna, and that's how they got it quickly, like approved in all these countries. Then, so they've been doing lots of testing. So they tested it and found out it was stable at a less severe temperature, and that you could thaw it and it was stable for longer, and et cetera, et cetera. So they didn't want a chance giving people what could be life-saving treatment by thawing it for too long and then not knowing if it was stable. So it's not because of weirdo chemicals, it's because they've had time to test the stability, and someday they'll probably develop it where it's just the fridge from the beginning to the end. But right now it's a regular freezer, not the severely cold medical freezers, to the fridge, and it's stable in the fridge for I don't know how long, but a day or more, something like that. So we know, I don't know how long because I'm not at the vaccine center where the ideas change all the time, but that's why. So they didn't pump in more chemicals, but that's a great question.
Well, we're at the top of the hour. This was incredible. I've had RA for almost 40 years and I learned a lot of things tonight already. So that's amazing. And we just thank you so much. This has been recorded, so it will go on our YouTube channel and we'll be promoting it through social media. We just really appreciate you stepping up and doing this for us, Dr. Pope, and all that you do for CAPA. And we thank you.
Great. And thank everyone for attending. And I'm sorry about that other night. I double booked myself by accident. It doesn't happen too often, but I'm glad for those who attended. And yeah, we'll get lots of interest, I think, by it being promoted on social media. So everyone have a good, safe evening. And now you're armed with a bit more knowledge, because there's a lot we all have to learn on vaccines, because it's a changing field for sure.
Okay. Well, thank you.
Good night,
Bye,
everybody.
Good night.
Bye-bye.
Bye.